To Alok. Alok is our next speaker.
Yeah, good morning. So I'll be
Talking about-
taking you through few of the cases. Every now and then, we at retina specialists, we get patients referred to us from our NTA segments colleagues saying that there is no improvement or, in fact, diminution of vision after cataract surgery. So the first case is a 65-year-old male who presented post-cataract surgery with loss of vision, and the history was of PCR and anterior vitrectomy. And you can see that there is an evident central retinal artery occlusion. And the FFA, although was normal, sometimes it is because of reperfusion, but OCT shows inner retinal hyperreflective, very suggestive of CRAO. Second case, again a 65-year-old, 60 years female, again had a PCR and anterior vitrectomy, and first post-op day, the vision was PLPR, and you see a very similar kind of FFA and OCT on the first post-op day. So CRA after cataract surgery is a known complication, although rare, and there have been several mechanisms which have been said, including vasospasm due to the periburbal injections of the anesthetic agents, adrenaline in the which we use, or because of the compression, mechanical compression it can cause, or raised IOP fluctuation during the surgery. The drug toxicity itself, sometimes we use some intracranial antibiotics. But what we noted in this series, the two cases that I've shown, was from a cluster of CRO that occurred within a month's time, 14 cases within a month's time, and we could find only one answer to it, and that was probably a residual ETO which was there in the probes. So, of course, systemic risk factors have to be kept in mind. This is a third case, which is a 60-year-old female who presented an hypertensive female. She had a post-op DM detachment, which was repaired by reposed by our cornea colleague. And on the first post-op after repair, there was a drastic fall in vision. And this is the fundus picture. You can see the tongue-shaped whitening of the retina in the peripapillary and foveal area and in the mid-periphery. Now this patient, if you see the OCT, you have hyperreflectivity of the outer layers. And this is suggestive of a posterior ciliary artery occlusion. And these patients can have occlusion if there is an acute rise of IOP, which could be due to pupillary block when you're using gas in these cases, and this reduces the blood flow in the posterior ciliary artery, and especially in a compromised eye. So the fourth case is a 71-year-old male who presented with diminution of vision after phacoemulsification, and the post-op day 1 vision 1/60. And you can see that there is disc edema, the margins are blurred, and there was RAPD. And this is the OCT and the picture of the same patient, and you can see on FFA there is differential filling and late staining of the disc. This is at 1 week, the vision improved spontaneously, and you can see that there is altitudinal field defect. So this was a case of NAIN which had occurred after cataract surgery. So risk of NAIN after cataract surgery is actually about 5 times higher than otherwise, and the risk is maximum during the first 6 months after surgery, and higher age group has been associated with this risk. The mechanism is again hypothesized as raised IOP or vasospasm due to regional anesthesia, or even post-op inflammation, which has been said. My last two cases are a 65-year-old male underwent uneventful small incision cataract surgery. Unaided vision at the time of discharge documented was 618, and the patient came back after 1 month with this fundus picture, and a vision dropped to 6/36. And you can see that there is an occlusion of the superior branch retinal artery. And what you also see in the periphery, these RP alteration with hemorrhages. Now, when we did FFA, you see that there is a lot of window defect or transmission hyperfluorescence in the periphery with the occlusion of the supratemporal artery. And you can see the hyperreflectivity on the OCT, inner layer hyperreflectivity on the OCT itself also. And again, another case with 19-year-old male who had sudden diminution of vision in the right eye, and he had history of trauma with a nail piece where there was a corneal tear repair was done. And during the tear repair, there was a subconjunctival injection of gentamicin that was given. And this was the fundus picture post when the patient was referred to us. And you can see that there is a large area of retinal whitening with occlusion of a vessel, and on OCT also you see hyperreflectivity. So gentamicin toxicity, we all know, it causes macular ischemia if it is inadvertently injected into the eye. But prophylactic subconjunctival injection of aminoglycosides can also lead to retinal toxicity, especially if it is injected near an area of weakness or where the sclera is thin. So these were my cases, and some of these cases we had over a period of time. Yeah, thank you.
You can continue.
So that's it. Yeah, I finished it. Thank you.
For being on time. Yeah, Dr. Manish.
Yeah, I think that was a great collection of cases. Unfortunately, nothing much we can do about them. It's a scary cluster of CRAO. Never seen that in cataract cases. But I guess very important take-home points is don't overinflate the anterior chamber. Make sure that the pressure doesn't go high, because cataract surgeons tend to make eye very firm. Intraocular injection, intracameral injection of vancomycin is known to cause HORV, so that's another important point. And I think it's also important for diabetic patients. We need to inform these patients about, the surgeons have to be informed about chance of DME. They need to prompt their patients that the DME might worsen. That's another vascular problem that might happen. Thank you.